Welcome everyone to another episode. Today we're going to be talking about foot and ankle injuries. Shaun, you're the foot and ankle guy, so I'm going to throw a few questions at you today, and we can have a bit of a discussion about that. So let's dive right into it, and we'll start with the three most common clinical presentations of foot and ankle injuries that you would see in clinical practice.
All right, well, first of all, I just want to say thank you for not calling me someone with a foot fetish. It is the foot and ankle guy, and there's a difference between the two things, and I just want to be really clear about that. So the foot and ankle guy I'm okay with. All right. The three most common injuries related to the foot and ankle, and it's a tricky one to narrow that down to three because there's a lot of things depending on the population you're dealing with. And so if I was to pick these out, I'd probably say the first one would be ankle sprains. And that can happen to anybody in any demographic. So ankle sprains would be one, lateral inversion ankle sprain. We then go with plantar fasciopathy, commonly called plantar fasciitis to a lot of people. The third one is probably going to be bunions and hallux valgus, which is not really an injury. They're more of an anatomical change that happens over time with a lot of people's feet. But then I guess you could probably go, if you're looking more the athletic population, you might look at something like an Achilles tendinopathy. But we'll go with the first three, ankle sprains, plantar fasciopathy, and bunions or hallux valgus.
Okay, so that's an interesting way to look at things to start with, because we've got firstly an acute injury in ankle sprains, we've got a load-based injury in plantar fasciopathy, and we've got changes in morphology, could potentially be load-based. There can be numerous factors that are involved in a hallux valgus. So let's start with ankle sprains. So you mentioned that it's typically the most common will be an inversion ankle injury. So we'll be looking at the lateral ligaments that are under high amounts of load and strain and potentially get injured. So what would our assessment and management look like of an acute ankle injury?
Yeah, well, I guess things have changed a little bit over time in how we manage these things. And if we go back probably even only 10 years, maybe a little more, the classic things are most protocol, right? Rest, ice, compress, and elevate for any kind of acute trauma or ligament sprains or acute soft tissue damage. And while that has changed dramatically, really the focus now has moved away from just controlling the inflammation to improving function and maintaining movement, range of motion, and very, very quickly returning to loading and developing or redeveloping and re-strengthening that joint. So the most commonly injured structure with an inversion ankle sprain is going to be the anterior talofibular ligament, which is a bit of an odd one given its location. It kind of sits on an angle at the front of the ankle. And you would think with an inversion movement, it might be one of the middle posterior ligaments of the ankle. But this one, it's because when we sprain our ankle, we're typically moving forward. So there's an inversion moment and then there's a plantar flexion moment. And those two movements combined tend to load that ATFL ligament, the anterior talofibular ligament, the most. So if we're looking to determine or isolate that as the source of the pain or the injury, palpation is a great way to do that. You can actually palpate that damaged structure, and then an anterior draw test on the ankle just to stress or load that tissue even more. It is difficult though, especially in the really acute stage. If somebody's presented to you within 24 hours or thereabouts of an ankle sprain, it's going to be all very sensitized, all very, very sore, and most tissues will be sore to touch because of the inflammatory chemicals in the area. So it can be very difficult to identify the exact structure. The more we learn about these pathoanatomical type injuries, the more we realize it probably doesn't matter in the very early stage how specific we are about understanding which tissue is damaged, if it's soft tissue based things. And it's more about trying to control that situation since we can. So the first thing they obviously want to do is unload that tissue so that they're not making it more aggravated, more sensitized, and potentially more inflamed. We might use some elevation. We're going to basically controlled rest or managed load. It might be that they can weight bear a little, and if they can walk a little and move a little, then we should encourage that, obviously to tolerance. And this is a general rule of thumb for any kind of acute sprain or soft tissue injury is move as much as you can to tolerance, because it starts to break this cycle of fear avoidance and starts to break the cycle of beliefs, negative beliefs that the patient might have about that injury, because very quickly they can think, okay, I've torn a ligament, therefore I can't put any weight on it, therefore I shouldn't use the limb, therefore I should just sit still and lay on the couch and watch TV, which is probably the last thing that they should do. Now we believe that movement's good. Movement will help to decrease the byproducts of that inflammation, but as far as like helping the skeletal pump to move those fluids out of the leg, it will help to maintain muscle function. It helps to regain, restore some of the proprioception at the joint even before we begin to load it. And that through that movement, we also start to encourage the healing process, which is obviously started by the inflammatory process. So if we go back to the Rice protocol, it was all about stopping the bleeding, the internal bleeding or the inflammation, reducing the swelling, reducing the redness and heat, and compressing that tissue, which basically takes the inflammation and says to it, we don't want you to get out of here. Of course, the inflammation is important, the healing process. And while we don't want it to be perpetuated, we want it to be managed. And we don't want to have somebody in a chronic inflammatory state where it's healing of those tissues. We want to just the process to go through its normal cycle as quickly and as efficiently as possible, supported by movement, activation, and maintenance of strength in that region.
Yeah, and that's so important, isn't it? You know, when we look at that acute inflammatory response, and we actually want to promote that, and how our evolution of understanding around management of soft tissue injuries has improved, as you said, from the Rice protocol then to the Police protocol, where it was, you know, integrating optimal loading as soon as possible. And now it's moved more towards the Peace and Love, which is, again, all about education, not icing it, avoiding anti-inflammatories, but promoting movement and exercise as soon as possible. Because, you know, at the end of the day, when we look at any sort of injury, we've got associated deconditioning that goes with it, changes in sensitivity and all of that sort of stuff. So we've got to, I think the most important thing when we look at rehabbing an injury is getting that baseline function back, reducing their pain, improving their range of motion, but baseline strength as well. When we look at strength over time, then, you know, if they're a netball athlete, we've got to get them back to netball. And how do we do that? By integrating the prime demands of what they do and what they actually need. So, you know, that's where it really should go from, you know, your basics as far as fundamental baseline strength into, you know, teaching them how to land, teaching them how to decelerate appropriately, then, you know, integrating acceleration, change of direction, all of this sort of stuff that will improve the capacity of their tissue and get them back to their return to play, return to function.
So like what I was talking about was really just that acute management. And a lot of people will end their management of the injury at that point. Oh, it's so done for if they are an athlete. And then those things that you just listed are absolutely critical. And even if they're not an athlete, they're just someone who needs to move, which is, of course, everybody. What are the demands of their daily life? Do they walk the dog? Do they walk commonly on uneven surfaces? Do they wear high heels? Is that a risk factor for them? Do they have to manage all of these things? And so the rehabilitation process from our perspective should incorporate identifying those needs and implementing them, and probably a lot faster than we might have once thought. Progressing somebody through those stages in probably a shorter time frame rather than thinking months and months before simulation of play or simulation of daily life, because the body's probably a lot more robust than we probably give it credit for. And we can use things like rigid taping and bracing and things to support them through that process of getting the function back. And we want to load the tissue fairly quickly, almost to tolerance, always under that high level of pain. A little bit of pain is okay, typically with soft tissue healing, but it should never be enough pain that causes them ongoing discomfort afterwards or increases their sensitivity while they're doing it.
Yeah, and that's such an important takeaway there that you said, Shaun, is, you know, a little bit of pain is okay. And we've got to get them comfortable with pain and get them comfortable with what is typically a bit uncomfortable and show them that that is actually okay. Because, you know, that whole narrative around, or stop if you feel any pain or let pain guide you, that's also quite outdated as well. Yeah, it can be sensitive, but that sensitivity does not indicate increased tissue damage or further injury. It's just about getting their nervous system comfortable with that. And as time goes on and load progresses, the level of pain intensity and severity will decrease, but the function will also improve.
That's right. And one of the things that perpetuates chronic pain presentations, which when we talk about chronic pain, often in the context of non-tissue related pain or non-tissue related nociception, and it's one of those things that we can do early on is encourage movement, encourage strength, maintain function. That's one of the probably the best things we can do to stop somebody getting into one of those non-tissue based nociceptive states where the pain is no longer an issue with the tissue, it's the pains in their brain. And so encouraging movement early on is often one of the best ways to stop that, I think.
Yeah, fantastic. Okay, great. Well, let's move on to the next one when we talk about plantar fasciopathy. This is another one that's sort of evolved as our understanding from, plantar fasciitis, plantar fasciopathy, heel pain, just in general. So talk us through this one.
Yeah, this is probably have to be the most commonly emailed question I get, from people who know that I've done a lot with lower limb stuff. They'll send me an email going, I've got with plantar fasciitis, we'll call it. What do I do to help that person? And of course, the answer is, well, it depends. It depends on a lot of different factors. Generally, it is a load management issue. And so people can develop a plantar fasciopathy, and we'll just call it, obviously for now, being pain, pain in the tissue or coming from that region. In that it can be a traumatic incident that can bring it on. Someone can jump and land onto that tissue and create the pathology. Or more often than not, it's a load-based, a repetitive load, repetitive strain to the tissue. And we get this micro tearing, typically the anterior part of the calcaneus, the head of the calcaneus, where the plantar fascia attaches to. And that micro trauma breaks down the soft tissue. And a couple of things can happen. One is you can get soft tissue induced nociception and pain as a result of that. The other thing that can then develop over time, particularly if this becomes a chronic presentation, is a spur. So essentially that's the anterior part of the calcaneus laying down more bone and to create more real estate for that plantar fascia to attach to. And you develop that little spur on the front of the bone, which interestingly, a lot of people have heel spurs, but no pain. And so a while ago, they stopped, and most good surgeons, I think, stopped doing surgeries for heel spurs because they were scanning people's feet, finding spurs, but not having any pain. And I thought it was really difficult to heel spur source of the pain itself. So now we typically just kind of ignore that and try to deal with the soft tissue loading-based problems. And so if we're trying to identify a plantar fasciopathy, it's generally pretty simple. There's a few kind of cardinal signs you look for. One of the first things would be either have pain first thing in the morning, or you'll typically sleep with our feet plantar flexed. It's hard not to in bed. The plantar fascia will shorten. You've got an already irritated, inflamed soft tissue that is maintained in a shortened position for 6, 7, 8, 9, 10 hours, how long you sleep for. And then you stand out of bed in the morning, it suddenly gets stretched, it's already sensitized, and it's going to create a new source of trauma, or potentially trauma, but definitely pain for the person. So that's a key sign first thing in the morning. Pain that typically gets worse in that region over the course of the day. So load-based, load-induced pain. So it's the loading it for many hours through the day, it gets worse. Palpation again, come back to push through the plantar fascia, get right up to the point where it attaches to the heel. Is that spot sore? There aren't too many things that can give you pain that exact site. There are a couple of things, but if you've got these other signs, pain first thing in the morning, pain worse with activity, certain shoes will bring it on, and you press the spot, you can be pretty sure 9 times out of 10 it's probably going to be plantar fasciopathy. And so that's how I would typically kind of identify them. There are other things, of course, but they're probably the first go-to things.
Yeah, perfect. And I think the history will give you a lot of information as well, is that they may have had some changes in load, changes in intensity, changes in frequency of training, and all of these things that start to sort of trigger a thought that you might think, hang on, this sounds like a load-based presentation. And, what's really interesting when we look at load-based presentations, the treatment intervention should be load modification, right? So talk us through, some things that might stand out to you from, common presentations. Typically in a lot of runners, you might see this. So how would you look at treatment or modification of load here?
You're right in that, if I think back the last After some people that I saw with this presentation, they're typically, the non-athletes are going to be people like hairdressers or chefs that are standing on hard surfaces for long periods of time. They're often gone into a new job that's increased their time in their feet, or they've gone into a new surface, a new environment, or they're just new to that job. And so suddenly they're standing, center of gravity forward over their toes. So that's more strain through the plantar fascia, often wearing hard shoes on hard surfaces. So that's a lot of load. So that would be typically one. If we look at runners, and I've seen lots of runners with this, it might be that they've transitioned from a very cushioned shoe into a more minimalist shoe, which I'm a fan of minimalist shoes, but the transition can often be problematic for a lot of people. And they might be running fast and hard on hard surfaces in shoes that don't provide pedal support that they may have experienced before. The transitioning into a minimalist shoe will eventually develop more strength in those soft tissues. It's the transition period that then leads to these problems for a lot of people, especially if they're overdoing it. And so it might even be that they've gone from an otherwise minimal type shoe into a very supportive shoe, a shoe that's got an increased arch support, or maybe they've gone into an orthotic. And we might think, well, that's odd, because normally those things help people with arch pain. Not if that support is actually pressing up into the plantar fascia and creating more stress and load on that tissue than it was normally had. And it obviously has to adapt to that over time, or maladapt to that, which is what we see with this. So those are typically the things you'd see. So changes in surface, changes in footwear, changes in the amount of loading they're doing on their feet, surfaces they're running on, distances. It's usually just an increase in something. Then when it comes to management, it's the first course of action is, okay, well, what are the aggravating factors for you? If it is that you are a chef or a hairdresser or someone, a pickup operator, and you're standing on your feet for long periods of time, I'd say the first thing to do would be get some kind of supportive that you can stand on. If you look at the supermarket, everyone's standing on rubber mats, takes a little bit of the cushioning out of the floor, or adds a bit of cushioning, I should say. It might be that you need to look at the shoes you're wearing. It might be that in your breaks, you actually get off your feet rather than just go and stand outside and eat your lunch. Sit down for a minute, give the tissues an opportunity to deload. And so even short periods of deloading of tissue can be enough to make changes. And then, of course, what are you doing when you're not at work? Can you get your feet out of those rigid shoes? Can you walk on some soft surfaces, challenge the soft tissues, keep your feet mobile? And then if we're staying with that demographic, when we go to system like us, what can we do to support that person? Can we mobilize their midfoot? Can we make it more flexible through that region so they can absorb and adapt to different surfaces better? And we look at some strengthening exercises through the plantar flexors, the intrinsic muscles of the feet, the extrinsic muscles of the feet, so that some of the load is being dispersed from the fascia or the plantar fascia into the dynamic tissues, the tissues that can create lift and support and unload some of those inert structures. And I would call the fascia the inert. It doesn't contract and it doesn't stretch very much at all. So taking some load into the tissues that can absorb by developing strength. Then we go to the athlete population. So if we go to the runners, the people who need to manage their load, then you've got to look at their training program. And it might not be within the scope of practice for every therapist to understand a training program for a runner. So I'd say refer to someone who will understand that if possible. It doesn't take too much effort to look at somebody's cycle over the last 2 to 3 months. If that's the thing that the pain's coming in, you know what's changed. Often it'll be they're increasing distances, they're increasing number of training sessions per week, and they're increasing speed. 2, 3 things all at once. We need to reduce at least 2 of those things if there's 3. So maybe we just drop a session a week. That can make a huge difference. It might be we change a speed session to a lower heart rate session, something we're just churning the legs over. It might be that a recovery run goes to a recovery walk. Something, if you can change, if there's 6 sessions in a week and we change 2 or 3 of them while we're taking that patient through the management process, can be enough to deload the tissue, give the tissue an opportunity to heal, change, desensitize, and then we can progress them forward from there.
Yeah, and I think that's what's so great is the modification, not the avoidance.
Yeah.
So, whether they're general pop versus athletic, it's all about modifying some things in their life. We don't have to modify completely everything or avoid everything. And the same with the athletic population, it's just changing and modifying variables. These presentations can be really difficult to treat and manage, and they can be a slow process over time. But yeah, that gradual and gentle modification over time is super important, along with addressing some biomechanical factors, as you mentioned, with these, some mobilization and external factors, footwear, running surfaces, all of that sort of stuff. So I think that's a really great overview there, Shaun. Okay, so let's move into the last one that you mentioned, which was a hallux valgus, or irritation or pain on the first metatarsophalangeal joint. So talk us through this one.
So when we talk about hallux valgus, the classic thing that most people visualize or think of is that bunion, and they are two separate things, but they'll often coincide. So if we think of hallux valgus, so hallux valgus is the great toe, the big toe, deviating laterally towards the second toe. And you'll see some really prime examples of this if you look at your grandmothers. It's typically older women, and so from this woman, it is a genetic predisposition a lot of the time, and it tends to be women more than men. You look at that sort of menopausal age group, 50s, 60s, and that big toe starts to deviate across. Now, it can happen in men, and it does happen in men fairly regularly, but I'd say far more commonly in females. Being a genetic predisposition, one of the first questions I'll ask to patients is, do you know anyone in your family that has this? If they start to think, my big toe's sore, is it moving? It's looking a bit different. And so if there is a genetic predisposition, it's difficult to stop. It's difficult to change, but we can manage. Another cause of it, before we get into management, is footwear. And so if you wear pointy-toed shoes, so a shoe with a narrow toe box, can physically deviate the big toe across, then through that bone position, we start to get changes in bony morphology. We'll get a wedging the first metatarsophalangeal joint of the first toe and the end of the first metatarsal, and get some bony adaptation as a result of that. And so I guess essentially a speeding up of osteoarthritis and some orthopedic changes, which will all develop anyway. The compression on the lateral side of that joint will sort of wedge the bone down over time. And then with enough friction and compression on that medial side of the first MPJ, you'll then develop this callousy type toothing over that area, which is essentially that bunion. So as the two bones kind of wedge open on one side, we're going to laying down this callus bone into that joint, and we get this big kind of semi-hard bony lump on that medial side of the foot, which is the bunion that we'll get with a lot of people. Not everyone will develop that. Most probably will if they have an excessive hallux valgus in the time. Back in the day, they used to shave that off. Not anymore, typically, because it's not a very successful surgery. It doesn't result in great outcomes. Now it's about trying to manage it as best you can. Wider toe box in the shoes. Another great thing that you can try is just using a little toe spacer, a little silicone spacer that sits in between your toes, a slightly bigger one between the first and second toe. And it just pushes that big toe into alignment and discourages that lateral deviation before unloading the joint, and will often reduce the pain that people experience as a result.
Yeah, and so because it's not just in a passive situation that's going to be irritable, right? So when we need that toe off through a normal gait cycle, and when that toe is in that valgus position, that can create increased stress at the first metatarsophalangeal joint. So also, along with those biomechanical factors, it can be modification of load to complement that as well. So I think that's important, because a lot of the pain that may be associated could be due to irritation of that joint and the synovitis that, as you said, Shaun, leads to some osteophyte formation, some changes to the joint. There can be some irritation to the bursa and increased load and stress on the surrounding tendons in that area. So these can be a bit of a multifactorial thing, although we see it as one condition. There can be a few things that are going on, whether they're primary or secondary. So that can certainly be a tricky one. I know even from an acute injury point of view, you can have incredible pain in that first metatarsophalangeal joint from things like turf toe and acute sprains and even dislocations around that area. I've had a pretty nasty one myself, and it can lead to that calcification over time, and it's got the appearance of that bunion look there. So yeah, they can be pretty nasty in acute pain settings as well.
It's an unfortunate reality of our foot biomechanics that as we go through the Kenneth cycle, the last point where we load the foot before heel off, or before toe off, I should say, is through that first MPJ. And so we transition from a supinated position into a pronated position and then drive off the big toe. It's a really important mechanical component of the foot. And so if you've got that hallux valgus where the big toe starts to deviate laterally, and then you start to then drive off that big toe. And we've all got a slight thing called a Fick angle, which is an externally rotated foot, just slightly. If you're excessively pronated, your Fick angle is typically wider. So if you've got that turned out foot, which we all probably do have, most of us do have, and you've got a lateral deviation of the big toe, now as you go to drive off that big toe, you're really rolling across the medial edge of the big toe. So movement is the problem. If you've got hallux valgus and you're standing still, it's probably okay. It's when we try to walk, which of course we have to do, but we force that big toe even more across at a certain point. But with that lateral deviation, it starts to self-perpetuate every time we walk. And so as we roll through that big toe, we're pushing it across even further, making it worse. And so, yeah, I guess another thing to think about too is maintaining function of that big toe. We see a lot of people with excessive hallux valgus or bunions as a secondary component to it, with a very rigid first MPJ. And so I would encourage your patients, where possible, to shoes off, because the shoes will force your big toe to go into more dorsiflexion. Move that toe, mobilize it as the therapist, keep it as mobile as possible. Encourage your patients to stretch their big toe into dorsiflexion to tolerance. And then maintain as much function and range through there as possible, because the second it starts to lock up on them and to get that osteoarthritic change, it makes the joint really stiff. It makes this problem even more painful.
And so from a manual therapy point of view, would you also be looking at improving, proximal factors such as the amount of midfoot mobilization, the amount of dorsiflexion to take some load off that distal joint in the first
joint? So much of what we look at in treating long legs and getting into the foot is maintaining maximal range through all these joints. And so when we've got dorsiflexion, when we've got subtalar movement, when we've got midfoot movement, and then BJ movement, if any one of those is deficient, the other joints have to make the difference for us to have smooth gait. And so, yeah, 100%, if you can't keep that first MPJ mobile, you'll have to work harder in the joints. And one of the things is make those joints more functional.
Yeah, fantastic. Okay, so great. That gives us a good overview of some common presentations, acute base injuries and some chronic overuse and some morphological changes that can be a result. So let's talk about some other injuries that we should keep an eye out for that may be a little bit more serious. So what are some other things that we should always have in our list of differentials when looking at foot and ankle injuries?
All right. Well, if you look at the athletic population, the classic one you have to consider is stress fractures. Whether there's metatarsal stress fractures, it might be a stress fracture through the talus, it might be even other places up through the ankle and into the lower leg. Stress fractures and stress reactions, one of those ones that kind of sneak up on people, and they can be super frustrating. I've had patients that have had just simple stress fractures, not complete fractures, that should have healed months and months and months before they did. And it kept them from their sport or from their job or activities for 6 months, 12 months longer than it should have, because they weren't managed well in that first stage. So the other challenge we see with stress fractures is they're very difficult to identify or to diagnose. You can sometimes see some stress reactions on an X-ray, which is where you'll see, tissue on the bone, a section on the bone that will be just more densely white. It's like colored in with more white paint in other areas. And that's often a stress reaction, which is where the bone is under load and it's absorbing more calcium into that section of the bone. It makes it more dense on the X-ray. And so while that might not be an indication of a stress fracture, it's often a reaction to load. It can be a precursor to a stress fracture. Stress fractures typically don't show up on an X-ray until about 6 weeks after they actually happen. So it makes it even harder to identify them. So it's often not until it's too late that you've then gone into the management protocol. So people with pain on a bone, tendons in the bones, it's unusual. It shouldn't be there. It can be from a single incident, but more likely from repetitive load. So you'd be looking at, again, those factors. Have they been increasing speed, distance, surfaces, changes, change in footwear, number of sessions per week, all of those things. And is there tenderness on bone that doesn't necessarily settle quickly when they unload that region of the body? And again, palpation can be a great way. Another trick is using a tuning fork, like a piano tuning fork. A level of very small vibration on the bone, vibrates through the bone, and will give you pain, quite intense pain as a result. So that can be another way to bring out fractures. And interestingly, it's about 10% of all reported sports-related injuries and stress fractures across the board. It's probably a bigger number than we give it credit for, again. So that'd be one. Another one, unless you wanted to dive into that one further.
Yeah, I'll just because that it is a tricky one, and because it is, like as you said, it's sort of that continuum where we have bone stress, stress reaction, stress fracture, and one of the reasons they can be so hard to manage is because when you talk about runners just like to run, and it's hard to modify their load because they say, oh, well, it's only when I run that I feel it. So outside of that, it might go on for quite a long period of time. And again, with this one, it is a load management one. But if there's a fracture identified, like we were talking about before with, ankle injuries that we need to load them up, it's sort of the opposite with stress fractures. When they do have a stress fracture, they need to be immobilized for a period of time, because obviously if that continues to go on, that can lead to a fracture and even necrosis. So it can be quite a serious injury.
Sure.
And yeah, it's one of those things that sort of needs to be picked up early and managed well, or it can result in serious injury.
Yeah, no, for sure. And when I've had patients with these injuries in the past, and you are right, runners just want to run as like a dog. If there's a ball, they will chase it no matter what. Yeah. I was one of those guys as well. So when they get to the point where they've been cleared for some light exercise, they want to maintain fitness. So cycling is going to be a good one. You're going to have that repetitive impact force. One of the things I found quite good for runners, if they've got access to it, is deep water running. So you put them in a swimming pool in a buoyancy vest, and you have them run on the spot. So they're going through the motions of running, the resistance of the water. They don't actually go anywhere, but just run on the spot, still cycling the legs, still swinging the arms, albeit I'm all frustrating because you've got to push through the water. Deep water running maintains the action of running without any load at all. It makes it is literally swimming in the water. So it can be a nice way to do it. And then, of course, you just got swimming as a form of exercise.
Yeah. And there are those really, really expensive treadmills now that you can do that, where it's sort of, you're sort of suspended running away. But just one more question to add on to that. So what would be so you mentioned metatarsal stresses, and would the other most common be a navicular stressy? Is there anything else?
This is a common one. I'll probably go more commonly through tibia.
Okay.
Tibial stress fractures, metatarsal stress fractures would be and I don't know the exact stats on this, but from what I've seen clinically, those two would be the most common ones.
Okay, fantastic. Okay, well, what do we got next?
Next one's probably less of a sports-related one and more of a morphology one, which would be the Morton's foot structure and Morton's neuroma. So Morton's foot structure, typically second or third metatarsal head, so where it articulates with the phalange, the bone that is kind of larger than it should be. And you'll palpate this through the foot. And the typical test is the Morton's test, which is you sort of squash the metatarsal heads together, and that will produce discomfort, either from the neuroma, so the little interosseal nerve that passes between the phalanges, or between the metatarsals. There's a little neuroma, it's a little growth on the nerve, and it can get squashed and be painful. Or the head of the metatarsal itself is a bony change, and it's larger and more painful. And you'll see people do all sorts of funky things with their gait, where they quickly transition from supination to pronation, rolling hard into that pronation movement, and then loading other structures. And so this problem, while it exists for a lot of people, can be fairly inconsequential for a while, but especially if they're on their feet a lot, especially if they're running or putting on going through the feet, they'll then often develop a cascade of other problems as a result. Surgery is an option, a relatively successful surgery for this one. Sometimes they'll shake down the nerve, sometimes they'll shake down the bone. I've seen people who have had this done and have poor results, and some have had good results. So that'd be another one to look at as well, the Morton's foot structure and the Morton's neuroma.
Okay, so how could someone sort of aid in managing symptoms from a myotherapy point of view? Is there anything that could potentially be done?
Yeah, so Because both of those things exist in the transverse metatarsal arch, which is one of our three arches of the foot. So we typically think of the longitudinal medial arch as the arch. We've also got a lateral arch, and we've got a transverse metatarsal arch underneath our metatarsal heads through the padding. This is the space where these two things can exist in the foot. And so one of the things you can do is use like a little donut cushion, which a lot of archers will prescribe. I think you can get them from a lot of chemists as well. So just a little round cushion with a little clamp in the middle that can sit under that bony or nerve-based pathology, so that when you do load it, it's lifted slightly. It's a little bit of protection. Generally keeping the foot mobile and strong, the intrinsic muscles, particularly the muscles that cross through that space to lift the arch, keeping them strong. So barefoot activity is great when the person's not in high levels of pain, to make sure their foot's nice and strong and mobile. Essentially just trying to manage their discomfort for them. We don't want them to have to get to the point where surgery is the last option. And people can live with these presentations. So having space in a shoe or wearing footwear that is going to not restrict the foot is going to be really important as well. Managing all those things in the hope that you might get some true resolution, or at least management to the point where they don't have to get surgery if possible.
And so your typical symptoms here is like walking on a pebble. Is that what people would describe? And maybe some sensory changes into the toes?
Yeah, so you'll get some sensory changes if it's Morton's neuroma. More likely you'll feel like you've got a little bit in the middle of the foot with a neuroma, or you'll feel like it's a Morton's foot structure. You feel like it's people under their toe, also under the middle of the arch, transverse metatarsal arch. And so it's just a space occupying problem. And it'll typically be when they're wearing restrictive shoes or walking on hard surfaces that they notice most.
Okay, great. That's some key signs to help you to identify it. Okay, so let's talk about one last thing. We often hear that the foot causes knee or hip injuries. Is this true?
It can be a contributor. Or it can coexist with these other things. It's difficult to say that one thing causes another thing when it comes to musculoskeletal, neuromusculoskeletal, or any other system in the body. And what came first, the chicken or the egg, is always the question. But if we can, and depending on what type of practitioner you are, you will have obviously a bias. Most of us have a bias to look for certain things. And those things are usually the things we know the most about. And so if you are a foot guy, you'll look at the foot and go, look at dorsiflexion here, excessive pronation here. You've also got medial knee pain. I think that might be coming from the excessive pronation causing internal movement of the rotation of the tibia, that's loading the medial knee, blah, 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 through the hip. Or if you've got a bias towards the pelvis, you might look at that and go, you've got an anterior hip on this side, and it's causing the rotation here, and that goes to the knee, and then, there you've got pronation. It's caused by the hip. You can see you can go either direction. And then when it comes to the management, we can look at it from both directions. We can go, you've got excessive pronation. Let's put an orthotic in there. They'll affect the knee load, they'll affect the hip load, and up into the spot near your back pain again. We don't really know when we look at all those things. And so I think I often use the analogy of an evidence book, right? Until you've got enough evidence pointing to one thing, you can't really be sure that it's the thing. And so if somebody comes in with medial knee pain and you think, it's an excessively pronated foot, now I've got an internally rotated hip, and I've got an asymmetry of the pelvis. Well, I would say try to change one of those things, or try to change the situation for one of those things, and see what happens. If I was to support your arch of your foot, do you feel like there's less load on the knee now? Well, it might be a contributing factor. Maybe that's something we can look at. Maybe you can use in the short term on the neurosurgery like that. While we strengthen you up so you don't have to rely on it. Or it might be, what if we were to take your hip or take something in your low back to change the position, change the load on tissue there? Does that feel better at your knee now? Okay, well, maybe that's what we want to do, strengthen those tissues. There's no doubt, though, that if you lack some key movements like dorsiflexion, it can be a really important functional one. So if you lack dorsiflexion, if you lack extension of the great toe, and you lack mobility through the midfoot, then the lack of movement in those 3 points will absolutely translate up through the chain. You won't absorb force as well, so you're more likely to get a foot and ankle related traumatic type injury, like a stress fracture or something else. And then, of course, you have to move more up through the knee and through the hip to be able to translate your body through space when you're walking or when you're running. And so mobility is important. Going back to the first thing I said, it's hard to say for sure what was the cause.
Yeah, I think that you summed that up pretty nicely there. And while you're more of a hip guy, I'm more of you're more of a foot guy, I'm more of a hip guy. We're going to look at things a bit differently, but it's important not to just have tunnel vision on that area. And we still will share a common theme there of load modification and symptom modification. What can we do to modify their symptoms in the short term, and then address these loading factors while we build up their capacity to be able to withstand that load? And while we don't necessarily need to change things so much, because people are in all sorts of weird and wonderful shapes and sizes, and that's fine. It's just that we need to modify their load, because we are very adaptable creatures. We will adapt to different types of load, but sometimes it is a bit too much or a bit too little. And while you may look at let's say a plantar fasciopathy, or it doesn't necessarily mean that foot needs to change. If they've got a flat foot, it doesn't need to change long term, but it might be the short term. There's some form of intervention that decreases the load on tissues, such as taping, or it could be orthotic for short term, until the body responds and adapts to that stimulus and load. So yeah, it's not that we need to change someone's structure completely. We just need to do it, figure out a way that we can modify their symptoms short term while we build up their overall capacity.
Yeah, this has been also one of the biggest lies that we've had over the last half century when it comes to do with feet, is like foot orthotics and footwear, changing foot position to modify a person's pain presentation. It's only ever a temporary fix, and if anything, it will lead to more deconditioning over time. You get someone with an excessive pes planus or flat foot, and you give them an arch support. You've just given a lazy person a set of crutches to walk around on. You haven't helped them. You've reduced their symptoms temporarily to make them even weaker. And so, if we're going to give some sort of external support or internal support, whether it's surgical or non-surgical, or taping or bracing or something like that, it needs to be a solution for symptoms short term, and then a solution for moving them towards a better state of health and function needs to be the long-term, medium to long-term plan: strengthening, increased mobility, increased function. All of that has to be part of the plan. The orthotic will never solve a problem. The different shoes will never solve a problem. It's always a temporary fix.
Yeah, fantastic. And it's so interesting as well, when you look at that, I think that's the issue of just assessing posture, assessing function, all of this sort of stuff in isolation. Well, you might watch me go out for a run and go, geez, that's ugly. It's got terrible technique. He's not very efficient. But if I manage my load appropriately, I can have absolutely no pain. So that's what's super important. You might not need to change, function and position and gait and all of that sort of stuff. It's just appropriate management of load over time. I think that's important.
Yeah, and I've done a lot of running coaching over the years, and one of the first things I really learned when I was doing that was that you don't have to make everybody run the same. You just have to make them more efficient for them. And, there's no one size fits all. And you look at, like you said, I might watch you run and think, oh, he's going to die at any minute. Like, he's going to burst in flames. And for you, it could work. And it's like anybody else, it could work. If their body, if they have tissue capacity that has adapted to that movement, that position, that load, the way that they move their body, almost anything's possible. It might not always be the most efficient, but it's always possible. And so unless you're a super top end athlete, or at least heading in that direction, perfection is a null point. It's most about tissue capacity and the ability to manage your body through the process of that.
Yeah, perfect. Shaun, that was awesome. There was so many valuable takeaways there. I hope everyone got just as much out of it as I did. So thank you so much for sharing your knowledge on the foot and ankle.
Pleasure. Thanks, guys.
Cheers.